All right, well, let's go ahead and get started. We are joined today by our special guest, Dr. Jesse Fann. He is the head of the Psycho-Oncology program at the Fred Hutch Cancer Center here in Seattle and is a faculty member in the Department of Psychiatry and Behavioral Sciences here at University of Washington. We had a request from the group to have some presentations and some discussion around collaborative care in specialty settings. So I reached out to Jesse. He and I have worked together on a project around implementing collaborative care in cancer centers, a project for which he's the principal investigator. I'll let you do a better job of introducing yourself, Jesse. But I will ask, one of the questions Jesse had for me was whether there's anyone in the group who's working in a specialty setting, especially an oncology setting. So do we have anyone on the call today who's doing collaborative care in an oncology setting?
Not doing in oncology, but rheumatology.
Okay, great.
Like we have one hand up. Erin?
Hi, this is my first time here. My manager, Dr. Elizabeth Nicole, who probably usually attends this meeting, asked me to come because I am working in an oncology setting doing collaborative and behavioral health integration. So
Great.
Wonderful, wonderful. Which clinic is that?
this is Summit Health in New Jersey, Florham Park, New Jersey.
Great, welcome. And I'll kind of follow up to that, Diane's question. Anyone, maybe not, currently doing collaborative care in a cancer setting, but anyone who is seeing cancer patients at all, as part of their practice, maybe not their full practice, but anyone's, in their practice do see the occasional cancer patient? So it sounds like most of you are in primary care. Of course, I'm sure some of your primary care patients have had cancer and hopefully have been successfully treated. And then some of you are working in specialty clinics. And, much of what I talk about will certainly be applicable to other specialty clinics. In our field of consultation liaison psychiatry, oncology is probably one of the largest, if not the largest, kind of specialty, within a specialty, if you will. So hopefully those of you who aren't seeing cancer patients can still get something useful out of my talk. So as Diane said, I've been doing psycho-oncology. I'm a consultation liaison psychiatrist and have been working within Fred Hutch Cancer Center for 30 years now. When I started, our service was about 5 people. I was the only psychiatrist, and now we have over 40 people in our team. We have been doing collaborative care at the Cancer Center since 2010. So I've seen everything from, a tiny referral model for psychosocial care to now, a very robust collaborative care program. We have 5 psychiatrists. We have 2 psychologists. We have 20 social workers. We have about 12 patient navigators as well. And we have 3 nurses. And we have an APP, and we're about to hire another APP. So the program's grown quite a bit. And for those of you who are interested in kind of, how we do collaborative care in this setting and how we've kind of grown and sustained this program, hopefully this talk will be helpful. So let me go ahead and share my screen. All right. Hopefully everyone can see this.
Yeah,
So
we can.
just wanted to, describe the importance of and challenges of providing integrated psychosocial oncology care, demonstrate how collaborative care can facilitate a population-based approach to integrated care, and then recognize opportunities and strategies for implementing and sustaining the model. Just a bit of background. So collaborative care, or I'm sorry, psychosocial issues are very important because the population of cancer patients has grown quite a bit over the years as we continue to age and people develop cancer, and we're getting better at screening and identifying cancer earlier on. Lots of contributors to distress and demoralization, which often presents with depression and anxiety in the cancer setting, but acknowledging that lots and lots of things contribute, lots of etiologies, not the least of which are many practical issues, transportation, financial, family issues, spiritual distress, loss of job, obviously lots of physical symptoms, etc. We know from many epidemiologic studies that about half of people with cancer generally cope relatively well with their usual support system. About a third might have what we would call an adjustment reaction, and then about 1 out of 6 have a major behavioral health diagnosis, such as major depression, panic, PTSD, etc. But we also know that the COVID pandemic has thrown a wrench into these and increased these prevalence rates. For those of you who aren't used to seeing a lot of cancer patients, there's a trajectory of cancer care that has periods where people are particularly vulnerable to distress, obviously at the time of diagnosis, but also at the time of initial treatment. Even now, as we get better genetic testing, people who test high risk are also at high distress. And then at completion of treatment is a time when a lot of people have increased distress. And we can talk about that more if we have time. When people have surveillance tests, CT scans to see if they're still in remission. Obviously, when people have recurrence or progression of their disease, when they enter more palliative or comfort care, and then advanced and terminal disease. So these are vulnerable time periods that we want to really watch for increased distress. The impact of distress in the cancer setting is, similar to other settings, but for the oncology providers that I collaborate with and for our cancer centers, the fact that distress really affects patients' potential to adhere and to complete their cancer treatment is a strong argument for the importance of psychosocial care. And obviously, these are very often sick patients with very life-threatening diseases, and therefore, treatment and management of their distress is extremely important for their quality of life, and also for healthcare utilization, and distress has been shown, particularly depression has been shown to be associated with increased requests for hastened death, suicide, as I'll show you, as well as an independent risk factor for mortality in this population. So I'll show you a couple of, quickly show you a couple of large national registry studies showing the pattern of mental health conditions at the time of diagnosis, shortly after diagnosis, and over the course of 10 years in this Swedish study, and even a higher rate of distress in the year prior to diagnosis. likely due to increase in nonspecific unexplained symptoms. This is a study that we conducted from our national registry called the SEER registry, looking at completed suicides in cancer patients compared to this red line, which is the general population. And you see that among people with cancer, very high rates of suicide in the couple of years following diagnosis, but remaining high even out to 20 years post-diagnosis. This is a Danish study looking at mortality across age ranges among people, among a comparison group with no breast cancer or serious mental illness. This gray line is the mortality among people with serious mental illness. This dashed line is mortality among people with breast cancer, BC. And then this top line is the mortality among people with breast cancer and serious mental illness. So obviously the contribution of mental illness to mortality in people with, in this case, breast cancer is quite significant. And then finally, this is a U.S. study from University of California, San Diego, looking at over 5,000 cancer patients, about a little over 10% with the diagnosis of depression. People with depression had much more annual non-mental health visits, as well as emergency department visits, hospitalizations, and rehospitalizations. And these odds ratios were even higher when comorbid with depression and anxiety. And actually more mental health visits were associated with lower healthcare costs. So a clear cost offset there if people with depression actually got mental health care. So that's the bad news. The good news is that there is emerging data now suggesting that if you actually treat the psychiatric problems, such as in this Korean registry study, you can actually decrease mortality. And mortality is a pretty high bar. So the fact that this study actually showed that if you treat mental health diagnosis, within 30 days of their diagnosis, it's actually associated with decreased mortality, both cancer related and all-cause mortality. And obviously some variation across different diagnostic groups. So switching gears a bit, what do we do about this? Clearly a huge need for psychosocial care in this setting and other medical settings, but how do we address this? And similar to primary care, we know from a number of studies in oncology that only about a quarter of patients with significant distress are adequately treated with guideline level care. About a quarter aren't adequately recognized or engaged in care. About a quarter stay on ineffective treatment for too long, and about a quarter drop out of treatment too early. So clearly not the picture that we want to see. There's been a lot over the last 15, 20 years or so of emphasis on screening for distress. People have come to understand that distress is very significant in this population, and a lot of accreditation bodies in oncology have mandated distress screening, which is great. Unfortunately, screening alone without a system to ensure access to evidence-based treatment is not sufficient to improve outcomes. Even, and this is based on a number of studies, referral to specialty care without close coordination and follow-up does not improve outcomes. And also even co-location of behavioral health specialists within the system, a cancer care clinic, without a system of tracking outcomes and making treatment adjustments does not guarantee improved outcomes. So patients are still falling through the cracks and staying on ineffective treatments for too long, even with mandated universal distress screening. So when I started working at Fred Hutch in the mid-90s, this was our model, our typical referral model that probably looks pretty familiar to many of you. Our oncology team would recognize some sort of crisis among one of their patients. For example, a patient, is not showing up for their chemotherapy infusions. They're spending all their time in bed, or they break down crying, or are suicidal, express suicidal ideation in the clinic, and then an urgent referral is made to psychosocial oncology, typically to psychiatry, sometimes to social work, sometimes to a psychologist, very, very haphazard and not well coordinated. And as a result, our model of care was basically treating about this, piece of the pie. Some people with, major mental health diagnosis, some people with adjustment disorder, even, some people who didn't really need it because they were asking for extra support. So obviously not the population-based approach that you want to see. Over time, as in primary care, the emphasis has shifted from a purely referral or consultation model to, in many cases, particularly in the large NCI, National Cancer Institute designated cancer centers like Fred Hutch, more of a co-located model. So a lot of cancer centers have social workers and typically psychologists, oftentimes not psychiatrists on site. Although COVID kind of messed things up, and I have visited a number of cancer centers where they lost, the psychologists lost their office space during the COVID pandemic and never got it back. So lots of cancer centers, all their providers are now purely offsite doing telehealth only, which works for some patients and doesn't work for others, and certainly doesn't promote a team-based approach. So the true gold standard is an integrated model where psychosocial care is really part of routine cancer care, and the providers are integrated within the patient's cancer care. So you've all seen this probably. I'm sure Diane's shown this to you. This is taken from the AIMS Center's emphasis on the 5 core principles of collaborative care, and these apply to psychosocial care and oncology settings as well. So we have to be population-based, and universal distress screening does help. It's a first step. Many centers are doing this, at least to the best of their ability. And at Fred Hutch, we actually do this through MyChart now. And we are getting, I think close to 70% of our patients, filling out the distress screening. We also have patients filling out the PHQ and GAD-7 before all of their social work and psychiatry, psychology visits. It's still not 100%, obviously. Patient-centered, it's very, patient-centered through use of a care manager. And in our case, an oncology social worker. As I mentioned, we have about the equivalent of about 15 or 16 full-time equivalents of social work. And each of those social workers is embedded in 1 or 2 oncology clinics, for example, breast clinic, or the GI oncology clinic, or the head and neck, lung head and neck clinic. And they function very similar to a care manager in a primary care setting. We very evidence-based. We track outcomes, PHQ, GAD-7, and other relevant measurements, and we treat to target. We use currently we're using an Excel registry, but we're all, as Diane mentioned, we have an NCI grant that is developing a web-based registry that integrates with a new patient app that that patients can use, that speaks directly with the registry that the social workers use. And then we really emphasize evidence-based strategies. We have weekly or bi-weekly case reviews. I'll talk a little more about that. And very transparent, very team-based. All our offices are next to each other. We consult with each other on cases on a daily basis. Very, very team-based approach. This is just to show you.
Jesse,
Oh,
just really quick, we have a question from
Yeah.
Laura
Yeah.
about, what are your thoughts regarding an oncology social worker versus a nurse as the behavioral health care manager? What are your thoughts about that?
Yeah, I think a nurse would be fine if they're, adequately, trained. The studies, actually, the top two studies here oh, not the top two, but the two studies by Sharp, actually the three studies by Sharp, Strong, and Walker were done in the UK, and they actually, used nurses as their care managers, because in the UK, social workers are pretty much purely doing navigational or practical needs work. So those are things that our patient navigators do to free up our clinical social workers to do clinical work, but certainly a well-trained oncology nurse who has good training in mental health can do the work as well. But this slide is really just to show you that these randomized controlled trials comparing collaborative care to usual care in oncology settings, really diverse oncology settings, including settings where they're treating. The Walker study is treating, end-stage lung cancer patients near the end of life. The L study is treating mostly women, Hispanic speaking women with, in a low-income setting, LA County. So very diverse studies showing very robust effect sizes. So turning to our setting at Fred Hutch, just to give you a sense of the population that we serve, we treat over 18,000 patients per year at Fred Hutch, at the main South Lake Union campus, which is right here, in addition to 5 community sites around the Puget Sound area. And obviously we see a lot of clinic visits as well as treating patients in the hospital. When we launched this, I had the opportunity to write a paper to kind of outline our vision with Michael Sharp and Kathleen L., who did a couple of the other randomized controlled trials showing the effect of collaborative care in depressed cancer patients. And so this paper kind of opened up the door to really talking about how collaborative care can be used in the cancer setting. And since then, we've published other articles, several chapters, and many more cancer centers have been trying to implement collaborative care in their cancer settings. So how we envisioned our Department of Psychosocial Oncology, which really involves an integrated team-based collaborative care model, again, since 2010. And we have psychiatrists, psychologists, social workers, and patient navigators, because all of these disciplines have an important role in the goal of really treating the whole continuum of psychosocial determinants of health in this population. And I'll talk more about it, but we really work together in a stepped care approach, and try to address both tangible needs and clinical needs among our patients. So we use this three-legged stool as a visual to kind of emphasize psychiatry, psychology, social work, and patient navigation. So many of you are probably familiar with the step care model. So here we have patient navigation, social work, and psychiatry, psychology. So for minimal to mild distress, many times our patient navigators can address things like financial issues, direct patients to community resources, support groups, help with transportation, housing, things like that. For patients with more mild to moderate distress, particularly related to clinical symptoms, our social workers are the first line to assess the patient and start a behavioral strategy, as I'll talk about. And then people with more moderate to severe distress can be referred to psychiatry or psychology if needed. This is our referral algorithm that we give to our oncology colleagues. So if the patient has purely tangible needs, they get referred to our patient navigators. If they have clinical needs, then we have a branching algorithm where if a patient has a history or current concern for substance use, we've stood up a dual diagnosis clinic within our clinic to help people with substance use concerns. If patients have complex psych history or medication regimens, then they can also be directly referred to psychiatry. But the vast majority of patients are referred initially to social work for an initial assessment and discussion at our case reviews. This is just examples of the tangible needs that our patient navigators address. In many settings, they don't have patient navigators, so social workers are still very involved with these. Our social workers still help with these if needed. These can be an important kind of entry point to talking about distress. So our social workers obviously are trained to help with these, but can also refer to patient navigators when these are primary issues. And then we deal with a wide array of clinical issues that we use a collaborative care model to help address. So just walking through, and this should look relatively familiar to you who are those of you who are familiar with collaborative care. We call our program the Integrated Psychosocial Oncology Program, or IPOP. So here's the oncologist, the patient caregiver, social worker, and psychiatrist, consulting psychiatrist. We have 3 consulting psychiatrists who do case reviews for our large team of social workers. So when we do identify some patients using universal screening, but many of our patients are referred by our oncology teams who notice patients in distress, and they really help endorse and facilitate psychosocial care. As with many medical settings, patients really listen to their medical providers. So our oncologists, really, we've trained them to really emphasize, and explain the reason they're being referred to our team. And then once they're referred, the social worker does an initial assessment, usually within a week or 2, and presents the case in our IPOP meetings or case review meetings. Because of the large volume of social workers that we have, we do case reviews every other week. Many of our patients, if they're in cancer treatment, they're with us for 6 to 9 months, sometimes longer. And if they have metastatic disease, they're often, being treated by Fred Hutch for years. So we found that, every other week, typically meets our needs for the majority of our patients. And those patients who are particularly complex, we can, because our offices are all close to each other, we can talk about patients more frequently as needed. And then the social workers, initiate typically a behavioral strategy, things like behavioral activation, motivational interviewing, cognitive behavioral strategies. And then if a medication recommendation is made, they communicate that to their oncology team that they're embedded in. These days, they do that typically through Epic inbox to the oncology team, copying the psychiatrist who did the case review with them, so that the oncologist knows that we've been involved and they can ask questions very easily if needed. We are seeing we are in person now, but about 80% of our patients are still being seen via telehealth. So it's very easy to communicate, with through Epic. If patients aren't doing so well, obviously tracked on the registry, then they're discussed again at our case reviews, and treatment adjustments are made. And if patients need to be referred to psychiatry or psychology, they're referred to us, and then we communicate directly to the oncology team at that point. So many of our patients are being seen by both psychiatry, psychology, and social work. Social work often continues to see the patient, help with care coordination, et cetera, referrals to community resources, et cetera. So our clinical social workers really do quite a bit. They, as I mentioned, care coordination, help with screening, brief evidence-based treatments, communication about psychotropic medications, tracking adherence, community mental health, and other resources, as well as providing support for our staff and incident debriefing for our oncology staff. They also are very involved with death with dignity processes for patients who are requesting hastened death, who are near the end of life. So when we onboard and orient our clinical social workers, we talk about the kind of a core set of interventions that we want all of our clinical social workers to have skills and comfort in doing. So we think about, obviously, kind of neurobiological factors that might be contributing to distress, things like genetics, family history, but also the very toxic medications that many of our patients are getting through chemotherapy and other therapies, and delirium and things like that. We talk about how many patients are very socially isolated, have a lot of avoidance behaviors, lack of pleasant activities, have a lot of psychosocial adversity. Many of them have had to quit their jobs or go on leave, or unfortunately are laid off from their jobs. A lot of them have family issues and issues with other role functioning. A lot of them are very sedentary, obviously, because of their physical problems. Start using substances or increase substance use, and then certainly lots of cognitive distortions about their body image and concerns, very legitimate concerns about their longevity. So how do we address these? We think about, obviously, medications, light therapy. We are in the Pacific Northwest, after all. We use a lot of behavioral activation. We use, in addition to case management, a lot of supportive therapy and problem-solving strategies. We use a lot of motivational interviewing strategies, and we make a lot of referrals to our physical therapy and integrative medicine and other support services. And then we do a lot of cognitive behavioral and mindfulness strategies. So all of our care managers need to have some training and comfort with these modalities. We have, as I mentioned, 5 community sites all across the Puget Sound. We also used to have a network across, the WAMI region. That network is being dissolved, but we do a lot of telehealth, and we do our IPOP case reviews over Zoom, because many of our social workers and psychiatrists and psychologists do spend a day or two working from home. So doing case reviews over Zoom works really well. So I don't need to go through this in detail because many of you know the strengths of collaborative care. I just want to emphasize that it really does leverage kind of our current provider models in psychosocial oncology. Many oncology clinics do have a team of social workers already. Some of them may or may not be clinical social workers. So all of our social workers, of course, are clinical social workers. And some of our community sites are relatively rural. We have a community site in, Paulsbo in the Olympic Peninsula, and it's been very, very important and effective in that clinic. It really has improved satisfaction with care, both from patient and oncology angles, but also for our psychiatrists and social workers. And we published a paper a couple of years ago that describes a survey that we administered in 2017 and in 2020, looking at various areas of satisfaction among our clinical social workers, and found that it really did improve their kind of work satisfaction, and allowed them to really practice at the top of their licensure, which is really important, and help them feel more integrated with our psychosocial team as well as with their oncology teams. So let's see, how am I doing on time? I want to leave time for questions, but I want to close with some lessons learned for those of you who are interested in potentially, launching or in implementing a model like this in your either oncology setting or your specialty setting. Very important for us to start with a successful pilot. Fred Hutch is huge, so you don't want to roll out something, and bite off too much at once. So we started with 3 very select, carefully selected clinics to show the benefit and success of the model. You have to be in it for the long run. I started at Fred Hutch in mid-90s, but wasn't able to really get this launched till 2010, which was very frustrating for me, and but I stuck with it, and it's been successful since then. It's really super important to develop close partnerships with social work and the medical team, in our case, oncology, and really nurturing our champions who can really help with implementation. Really prioritizing, in our case, hiring patient navigators to free up our social workers to do more clinical work, to support our providers and staff. We negotiated for administrative time for our psychiatrists and psychologists, which really decreased our turnover, and providing dedicated peer support activities to prevent burnout. We engaged the whole team in educational and research missions. As we mentioned, we have a large NCI grant that is involving a number of our psychiatrists, psychologists, and most of our social work team, which has been really gratifying. We're collecting accurate data to support resource needs. Every year we have to put in requests for more budget, our budget requests, and Fred Hutch has been extremely supportive of us, mostly because we have good data, and we're able to show the need and the need for psychosocial care and the need for more resources, and then really continuing to innovate. We are at a research center, University of Washington and Fred Hutch, which is a major research center. So we did innovate by integrating substance use treatment. We want to increase our care for serious mental illness. We want to integrate more with palliative care. We want to do more research. So these are all things that we're continuing to try to innovate on. Now, this doesn't mean that there aren't ongoing challenges that you should expect to encounter. Recruitment of people with both interest and expertise in psychosocial oncology, or whatever kind of specialty clinic you work in, can be very difficult. There's probably only a handful of psychiatrists in the country who are really well trained in psycho-oncology. So recruitment and retention, and providing a pathway for trainees to potentially join our team as attending. So we've been able to launch a brand new psycho-oncology fellowship that is ACGME approved. That's going to start up in July. So we're currently, I think the match list goes in tomorrow for our brand new psycho-oncology fellowship, which will be the first one on the West Coast and the third in the country. But some turnover at startup is going to be common. Maintaining a standard of work and minimizing drift is really a challenge in any setting. So continuing to do kind of education and finding ways to make sure that the workflows are working well and core competencies are maintained. Coordination across other supportive care services. You want to always minimize duplication of services. For example, with palliative care, with integrative medicine, they do a lot of mindfulness meditation, acupuncture, spiritual health, that does counseling around spiritual distress. So you want to coordinate with those great services, but not duplicate care. And then transitioning patients to the community following cancer treatment is a real challenge, because community resources are limited and we can't hold on to patients forever, even though many of our patients want to be held on forever because they're getting good, really top-notch behavioral health care that they would not be able to easily get in the community. But we continue to get lots of new cancer patients, and we have to, have capacity to care for them. Let's see. The gold standard is to integrate our registry with the electronic health record, EPIC. In our case, we still need to do that. We're hopefully working towards that. And then we do not reimburse, we do not bill for collaborative care, although we could, and some cancer centers are doing that now, but Fred Hutch has not made that a priority. So I'm going to stop here and see if there are any questions.
So Jesse, we had one of the questions that came in was about billing. So you just answered that. So that's great. And then Carol asked a follow-on question that says that, if you're not billing for services, how do you pay for the, very robust psycho-oncology team that you have? Do you know sort of how the financial model works for that?
Yeah, it's a great question. Of course, you have to pay for what you asked for. So, some of this is historical. Social work at Fred Hutch has never billed, and they, along with some other support services, for example, nutrition, does not bill. And spiritual health does not bill. Our chaplains don't bill. So, historically, Fred Hutch has found or felt that, part of their mission is to provide those supportive care services for their patients at no cost. Now, of course, not every cancer center can do that. And Fred Hutch has lots and lots of donors, and you know, they actually do pretty well with you know, with their financials. But that's not gonna, you know, necessarily always be the case every year. So I, you know, I do anticipate that eventually we may start billing for collaborative care, but that hasn't been a priority. Now, for psychiatry and psychology, we do bill. We bill for every one of our professional encounters, and bill a professional, you know, a pro fee for that. And it's a complicated, you know, funds, you know, arrangement where Fred Hutch pays for certain part of our FTE that we work at Fred Hutch, and then, you know, most of our providers get our salaries from University of Washington. So basically, Fred Hutch pays University of Washington Department of Psychiatry for the work that we do, and they've been very generous with that.
Shanda also asked a question saying that it sounds like your oncologists are willing and able to do things like prescribe psychotropics and handle mental health issues. Would you find that to be true? Does that seem true in your experience?
Yeah, another great question. So, you know, we have hundreds of oncologists here. So, you know, some oncologists, you know, are super comfortable with it. You know, some consider themselves psychiatrists themselves, and you know, don't have any problems, you know, prescribing psych meds. And then some are very, you know, very reluctant initially. And so one of the things that we found to be, and it would strongly encourage anyone thinking about implementing this, is spending you know, dedicating time to do in-services with each of the clinics that you work with. So we have, you know, a breast clinic, we have a lung, head and neck clinic, we have a sarcoma clinic, we have, you know, a GI cancer clinic, we have a number of breast clinics, we have gynec clinics. So we have to meet, and we make it a point to meet with each of those clinics every 1 to 2 years to give them a, you know, it doesn't have to be a you know, an hour long. It can be a 20 to 30 minute in-service to really, you know, update them on our model of care, and also update them on, you know, our providers and how we, you know, you know, our model works. And I always do these in-services with the social worker embedded in that clinic, so that they know that the social worker works hand in hand with us in psychiatry. We're all in the same department, and we, you know, we make ourselves available. If they have questions or concerns about the recommendations, medication recommendations, then they can always reach out to us with clarifying questions. And when we do that, we hardly ever get pushback, and we hardly ever get even questions. You know, our social workers are trained to, you know, the basics of, you know, psychopharmacology. Obviously, they don't prescribe, but they have, you know, good, you know, resources to know some of the basics, and can always ask us. So that is what really, I think, has made the difference in helping, you know, our oncologists to feel more comfortable.
So Carol asked another question about do your psycho-oncology team folks use traditional 1 hour sessions or half hour, et cetera? I know that might vary based on whether that's the clinical social workers doing things like behavioral activation or things like that, and maybe your psychologist, so you know, or psychiatrist. So can you talk a little bit about what the structure looks like in terms of length of sessions?
Yeah, we have been, you know, ever since I took over as the medical director in 1999, I think it was, I've been able to really advocate for 1 hour sessions. So for all of our providers, our psychiatry and psychology and APP providers, I give them, you know, the freedom to schedule 1 hour sessions with their patients. And also the freedom to schedule half-hour sessions if a 1 hour, full hour isn't needed. And the reason I think that's really been helpful for us is, number one, with a collaborative care model, we in psychiatry, psychology should be seeing the most complex patients, right? Because people with more mild to moderate distress, should be handled by our social workers. So when patients get to us, they should be treatment resistant or more complex, and often, in oncology, as with many medical settings, you can't treat the demoralization and existential distress and depression with the medication alone. You have to do some level of counseling / psychotherapy, and our social workers do some of that, but our psychiatrists all are very interested and well trained in psychotherapy. And so I think to serve the patients the best, and also to prevent burnout. This is a highly, distressed population, very medically complex, and if you've got 30-minute back-to-back appointments all day, you're gonna, I can guarantee you, your providers are mostly gonna, easily burn out. So the 1 hour appointments, and our social workers also, I believe, have mostly 1 hour appointments. Although, if they're doing, some navigational work with the patient, they may not need the full hour, certainly. But that flexibility has really been helpful.
So we've got a couple of questions that are related. So Laura says, how does your team navigate decision-making for patients in the complex category needing psychiatry or psychology versus collaborative care? So in that step care model that you were talking about.
Mm-hmm.
And then Tisha kind of piggybacks on that, wanting to hear more about the role of psychologists on the team and how their role is different from the clinical social workers.
Yeah, great questions. I would probably describe our model as a blended or hybrid collaborative care / co-located model. So, I know that in a lot of collaborative care models, the psychiatrist doesn't see a lot of patients themselves. They mostly, act in a consultation role with the care manager. So our psychiatrists do that. But because of the complexity of our population, certainly anyone can get cancer, and that means, anyone with bipolar disorder or difficult schizophrenia can get cancer, and they're treated, at our cancer center, but because of the complexity of our patients, we have requested resources to have psychiatrists be able to see, a fair number of their own patients over time. We don't see patients as, their primary, mental health provider for indefinitely. Our main goal is to help people get through their cancer treatment. So we may often, psychiatrists often see patients for 3 or 4 sessions, and then maybe transfer the patient back to their social worker, and then eventually to the community if needed. To answer your second question, our clinical psychologists are really available to help with complex and difficult behavioral health issues. So people with chronic, suicidal ideation, people with borderline personality traits, people with, significant eating disorders, people with, very difficult post-traumatic stress disorder, people with behavioral issues that are impacting their cancer treatment. So our social worker or our clinical psychologists really are focused on those kind of difficult behavioral strategies that require more frequent visits, and that our clinical social workers may not feel as comfortable taking on by themselves. Hopefully that answers your questions.
And then we've got, Tisha, did you want to follow up on that at all?
I was gonna say, yeah, thanks. That's really helpful.
And then we've got time, just a couple minutes left, but a question from Ben. Do you engage caregivers in your model? I've found great value in using the caregiver strain index in the pediatric space and may add value in oncology. What are your thoughts about that?
Yeah, really important point. Caregivers are critical to the care of patients with cancer. We often will include caregivers in at least part of our sessions, with the patient. Our social workers are actually, because they don't bill, they're actually available to provide support for caregivers, and often will actually meet with caregivers individually. Caregivers aren't registered patients in our cancer center, so our psychiatrists and psychologists can't, see them individually. But if they need, their own mental health care, we certainly, help them find, community resources for that. But our clinical social workers and patient navigators are available to assist caregivers. Very important.
And then we've got 2 minutes left. Another question from Carol just about, is 6 to 9 months the normal time frame for patients? I think you talked about that a little bit. It kind of depends on the cancer trajectory, but even within that, you also, I think, just said that sometimes you just need 3 or 4 sessions, with the psychiatrist or the psychologist. So maybe you could just talk about what you see most commonly.
Yeah, I would say most commonly, 6 to 9 months is the most typical trajectory. Cancer care continues to really advance at breakneck speed. So, our cancer care that we're providing now is very different from even 10 years ago. We have so many patients with metastatic cancers that are surviving for years, that when I started would have been dead in a month or two, so and then many of our cancer treatments are oral now. They don't require people to come in every 2 to 3 weeks for infusions. So so many of our patients are living much more active lives, but it also doesn't mean that they don't need ongoing behavioral health help. So yeah, it just continues to evolve quite a bit.
Well, we are at time. Jesse, if you'd be willing to share your slides with me, I'm happy to post that to the Basecamp site so that people can refer back to those. There's always a recording of this that the CFHA folks do, and that also gets posted into the Basecamp site. I don't know if you've got another minute. There was one more question from Laura about the size of caseloads.
Sure, and let me turn off my phone. Sorry about that.
Yeah, okay.
Sorry about that. Yeah, size of caseload. So I'm assuming for the care managers.
Yeah, I think so. Yeah.
Yeah. So the size of caseload has to be a bit smaller than in primary care settings, just because of the complexity of the patients, how sick they are, how long they stay with us, and so and it also varies quite a bit based on the cancer clinic. So for example, our bone marrow transplant clinic, our social workers have, relatively small caseloads, around 10 patients at times, because these patients are very, very complex, and they're in, their trajectory while they're here, typically for at least 100 days, is very intense. And that differs significantly from, for example, our breast oncology social workers that have sometimes closer to 30 patients that they're following. So, I would say, anywhere more than 30 is getting pretty difficult for many of our social workers if they have a caseload more than 30. Again, because of the nature of the patient population.
Thanks so much. That's so helpful.
Other
I think
questions?
Diane I think Diane had to hop off to another
Okay.
meeting. Thank you
All right.
so much. This was really, really helpful, and I'm sure you'll have some people reach out to you with other questions. I think you've got such a great program, and thank you so much for sharing.
My pleasure. Hope it was helpful. Thanks.
Bye, everybody. Thank
Take
you.
care.